Well, welcome everybody. Thank you for joining us this morning. We'll get the program started, and I'm going to start us off. I want to let me just introduce myself first. I know just about all of you, but maybe not everybody in the audience. I'm Tim Bricker. I'm the president and CEO here at Mercy Gilbert Medical Center, as well as at Chandler Regional Medical Center. And I'm really thrilled to see all you here today. We have a terrific program for you this morning. We have a great panel. I'll introduce our panel members in just a few minutes. You can see the topic on the screen behind me. Implications of the Affordable Care Act, a hot topic really for the last several years. Actually, I'll share with you a little story showing that this has been a hot topic for more than just a couple of years. As I was thinking about the discussion this morning and the presentations that we're going to have, it reminded me of way back in my early career. I had just graduated from college back in, I shouldn't even tell you that one. It was 1989, and I majored in public policy and government. And I went to Washington, D.C. I lived in Portland, Oregon. I went to Washington, D.C. I had a 30-day round-trip ticket. I was either going to find a job and work on healthcare policy in Washington, or I was going to go back to the West Coast and do something else. So I hit the streets in Washington, D.C. I really pounded the pavement, and I hounded everybody that I could talk to. And it was, if you rewind in your minds back to the late 80s, it was healthcare reform. That was the hot topic in Washington, D.C. at the time. It was the latter part of the first Bush administration, and it was during the election, and President Clinton was coming into office, not too long after I got there. I ended up getting a job for AARP, the American Association of Retired Persons, and I wrote AARP's plan for national healthcare reform in 1989 and early 1990. So I was looking through the materials for today's discussion. I was thinking about the panel presentation. It's the same thing. I gave this presentation in 1990 to a group of staff members at AARP, helping support their lobbying efforts. So it gave me comfort that I've given this presentation before as I got ready for this morning. It really is remarkable how the topic hasn't changed a great deal. Let me cover a few logistics and housekeeping items for you, and then we'll get into the program. The restrooms are just this way, to my right, to your left, down the hall. So if you go out the door, back toward the elevators, you'll find restrooms right there. Please put your cell phones, your iPhones, whatever you have on stun or vibrate, just to help with peace and quiet and feedback from the microphones. We have a lot of materials for you as well. In the back of the room, on the table, near where most of you came in, there are stacks of information, really good information from a variety of organizations about the healthcare reform law, about implications of healthcare reform. I won't tell you everything that's back there, but we have some information from Dignity Health about what we are doing. Dignity Health is the parent organization for the two hospitals that I oversee. We have information from the Kaiser Family Foundation, an organization that puts out really terrific information about health policy, and there's a fact sheet back there for you. Gamage and Burnham has a list of frequently asked questions about the healthcare reform law. That's a terrific resource, and on and on. There's also, I actually have a copy here. You can't see this, but there's a one-page fact sheet back on the table from Governor Brewer's office that provides, it's really the best, real short version of the governor's proposed Medicaid expansion or access program expansion. So you may want to grab that and take a look at it. And if you have questions or you want additional information, let me know, let other members of the staff know, and we'll be happy to provide more information for you. Two quick introductions and thanks just for the program today. First of all, Suzanne Feaster is with us this morning. She's our Vice President of External Affairs and Government Relations for Dignity Health. Really was one of two people behind setting up this program this morning, so thank you to Suzanne. And if you have any questions or if I get anything wrong, that's the person to ask. And then Julie Graham is here also, who is responsible for public relations and marketing and government relations for the hospitals here in the East Valley. And Julie has had a substantial role in getting the program organized this morning, so I want to thank and acknowledge Julie back there in the back of the room. So here's what we're going to do. I'm going to spend a little bit of time taking you through a few slides, giving sort of a high-level overview of the Affordable Care Act, or the healthcare reform law. And then we'll have each of our distinguished panel members spend a few minutes presenting on various topics related to the act, and then we'll open it up for questions. I would say feel free to raise your hand and interrupt me. I won't be so bold to suggest you interrupt our panel members. I'll let them offer that instead. But feel free to interrupt, ask any questions along the way. We'll take one or two, and then we'll have time at the end for more substantial Q&A. So it's probably fair to say that there's not a public policy issue that has attracted more attention in the last, based on my story, 25 years, but at least the last couple of years, than healthcare reform, with the possible exception of the fiscal cliff. It's a complex topic. It can be awfully confusing, and it's probably fair to say that at the very least, there has been potentially some confusion and maybe some misinformation out there. So I think part of what we hope to do today is to provide some facts and some objective information to help you in whatever role you serve in have a good understanding of what we're facing as a country, as a nation, as a town, as a state, as an industry, from whatever focal point you're viewing this. So that's really what we hope to achieve today. It's also really important specifically for business to understand what's going on, because the Affordable Care Act has significant implications for businesses of all size, obviously. And so I think there's probably a little bit of a bent toward information helpful to business. Let me just ask, again, I know many of you, but from raise of hands, how many of you here either work in or are representing small employers, let's say businesses with fewer than 50 employees? Yeah, quite a few. So that's great. We'll have some good information. Let me do a couple more introductions, and then I'll get into the slides. We have at least 2 elected officials with us here this morning. We may have more that I didn't see walk in, but over on your right, on the right side of the room, we have 2 of our town councilmen from Gilbert. We've got Councilman Eddie Cook here with us today, and we have Councilman Jerry Taylor here with us today, so welcome. I also see Patrick, our town manager, Patrick Banger, wandered in, so welcome to the 3 of you. We're really glad to have you here this morning. All right, my presentation is moving ahead. Let's see, where's my clicker? Here it is, got it. Okay, so quick, short presentation, and then I will introduce our distinguished panel members here. So just a little bit of background. Why did we pursue healthcare reform? This is where I was thinking this is the same story as it was 25 years ago. The status quo was unsustainable. We were saying that back in the late 80s and the early 90s. The status quo in healthcare in this country is unsustainable. We have still about 50 million people without health insurance in this country. The cost of employer-based health insurance, which is where most people get their insurance in this country, now totals over a quarter of the average family's income in this country. So as we all know, very, very expensive, and the costs continue to go up and up. The Medicare program, the program for the elderly and disabled in the country, government-funded insurance, at this point is estimated to go broke in 4 years, based on objective analysis. What we call there's an enormous cost shift within the healthcare system, what we call a cost shift, $90 billion annually. What that basically means, from my perspective as somebody that runs hospitals, is government-funded healthcare programs like Medicare and Medicaid, they don't cover the full costs of what it costs us to provide care. Instead, and as a result, what we do is we shift those costs over to private insurance and to those of you that work and that run businesses. So there's a essentially $90 billion subsidy from the private sector to government-funded health insurance to help us in this business balance our books. We are experiencing ever-increasing charity care and uncompensated care, because when folks come to the hospital, whether or not they have insurance, we are required to treat them. And as a result, hospitals and physicians across the country are experiencing significant increases in uncompensated care and charity care. We have a very fragmented healthcare system, and any of you that have used it probably have had that experience. We have doctors and hospitals that kind of work in silos. We have tended to work independently of one another. The way that we are paid within this business is such that we get essentially paid for everything that we do, and we don't necessarily have an incentive to work together. So if you come to a doctor and you have some tests, the physician gets paid for those tests. If you come to the hospital, we do what we do, we get paid for whatever we do, and there's really not a lot of financial incentive or other incentive for us to work together and coordinate care across a pretty complicated system. So that whole set of dynamics drives up costs. It drives down quality through lack of coordination and lack of standardization across different care providers. And by contrast, we would of course all expect that patients, that you and I should expect what we call here the highest possible outcomes. Basically, the best healthcare quality, right? You should be able to get safe care, the best care, care coordinated across different providers, and it should be at an appropriate cost. We've been far from that for a long time in American healthcare. So that's just a little bit of background on why healthcare reform. So how was the Affordable Care Act, the ACA, designed to expand healthcare coverage? Because that was obviously one of the most critical aspects of this law, expand healthcare coverage to those that don't have insurance in this country. The law is projected to reduce the number of uninsured people in the US by 32 million. So it's not 100% coverage, but it's close to 100% coverage. The way that those 32 million people are intended to get health insurance is basically split between two different ways. Half of them covered under a streamlined Medicaid program, which is called Access in this state. Access stands for the Arizona Healthcare Cost Containment System. That's our Medicaid program. The other half covered through reformed commercial marketplace, through employers, through healthcare exchanges, which we'll talk a little bit more about. And then there are tax credits from the government to make coverage more affordable for people that can't afford it. And the exchanges, again, which we'll talk a little bit more about, a new entity to make coverage more accessible for people that have not had it historically. So this little pie chart I find interesting. It shows you how the expanded coverage breaks down for the 32 million people who are intended to be newly covered under the Affordable Care Act. What's interesting about this is some have the impression that there is a significant new government involvement. You hear language around government takeover or significant government-provided health care. This shows you that over half of the new coverage under the Affordable Care Act for folks that didn't have insurance in the past comes through employers. So really this is in large part a continuation of our traditional employer-based health insurance system in this country. You can then see the breakdown. The next largest piece of the pie comes from Medicaid and CHIP, which is the Children's Health Insurance Program at the state level, and then the exchanges, non-group individual and other insurance, and then 23 million people are projected still to be uninsured even after the law goes fully into effect. So this is Tim Bricker's top 10 list for today. The 10 key elements of the Affordable Care Act. This is intended to hit the highlights, and then our panel members will speak in greater detail to various elements. So here are the top 10 key elements of the Affordable Care Act. First, there are a lot of insurance reforms in the law, and here are a few. No lifetime benefit limits and no annual limits on coverage. So traditionally, we would have a set lifetime limit, $1 million, $2 million on total benefits. Under the Affordable Care Act, there are no more lifetime benefit limits and no annual limits on your and your family's coverage. Number two, health insurance coverage cannot be denied based on health status. So if you're sick, you can still get health insurance coverage, whereas in the past, coverage could be denied based on health status. Number three, dependent adult children can stay on their parents' health policy until age 26. That's gone into effect. Again, show of hands, how many of you or your kids have benefited from that change in the health insurance law? I see a few. Good. Number four, no insurance coverage exclusions for pre-existing conditions beginning next year, 2014. So you can't be excluded for pre-existing conditions. Number five, an item that obviously has received probably most attention as the law passed, mandated insurance coverage. So essentially, everybody is required in this country to have, I jumped ahead, mandates coverage of preventive care. The Affordable Care Act mandates that as part of a standard benefit package within health insurance that preventive care is covered. I'll get to the individual mandate in just a minute. Number six, coverage can't be canceled when someone gets sick. Number seven, the Act limits insurance companies' ability to set premiums based on health status and other factors. So in the past, your rate, your health insurance premium, could be influenced by various factors such as your age, your illness status, your gender. Those sorts of things are not allowed anymore. Number 8, the Act creates a new marketplace called an insurance exchange, which we'll talk more about, to help people find and purchase insurance. And number 9, it provides subsidies to help people buy insurance through the exchanges. And the availability of subsidies is tied to various percentages of the federal poverty level, so those that need help can get some subsidy. And then finally, here it is, the individual mandate. The law requires all Americans to have health insurance through one form or another. So there's my top 10 list for the day. The 10 key elements of the Affordable Care Act. What about your coverage today? If you have health care coverage today, will that change? How will that change? Most individuals that have health insurance coverage through their employers won't see substantial changes under the healthcare reform law. Although the bill does include incentives for employers to provide coverage and continue to provide that coverage. So if you're insured through your employer today, you should not expect to see substantial change in that situation. Individuals who buy their own insurance, not through an employer, may be eligible for coverage through these exchanges that we'll talk about, and you may qualify for tax credits to help purchase coverage depending on your income level. What about for employers? This is a little bit of a interesting fact here, and we won't get into too much detail, and members of the panel can answer more questions. Large employers, there are incentives within the Affordable Care Act for large insurers and small insurers to continue to provide, or to provide anew coverage for their employees. So businesses with 50 or more employees, in the Act defined as large employers, businesses with 50 or more employees will actually receive will be fined if their employees purchase health care coverage through the exchange and receive some sort of subsidy from the government to do that. So it's a financial incentive for employers to provide adequate coverage for their employees. Small businesses are eligible for subsidies to offer insurance and will have access to purchase that insurance through these exchanges. So there are some differences between how the law impacts large employers and small employers. But really what it means is that there are incentives built into the law, strong financial incentives, to continue with the employer-based health insurance model that we have in this country today. Medicare, how will Medicare change? Individuals that currently have traditional Medicare coverage should not see much change. There will be some additional benefits, however, such as free preventive screenings, such as colonoscopies, mammograms. You could come to Mercy Gilbert and receive those services. A free annual physical or wellness visit, and discounts for brand name prescription drugs. Individuals that have Medicare Advantage plans may see some changes. Again, I won't get into the details. If you have questions, we on the panel later can talk about what those changes are. For folks that are uninsured, starting January 1st of next year, all U.S. citizens and legal residents in the country must have coverage or pay some sort of penalty. It's been called many things, but pay a penalty of some sort. Eligibility for Medicaid is expanded to low-income individuals, again, depending on what the income level is as a percentage of the federal poverty level. Uninsured individuals that are above eligibility for Medicaid have access to purchase coverage through the healthcare exchange. And then, again, subsidies will be available depending on your income level to help individuals buy private insurance. Financing reform. How will the expanded coverage be paid for? Several new ways. There are spending cuts, and there is new revenue tied within the Affordable Care Act. These spending cuts that you see affect us, affect me, affect the healthcare industry primarily. Those of us that are doctors and hospitals and other providers of care. Savings from Medicare Advantage and Medicaid, so reductions to funding for the Medicare Advantage program and the Medicaid program, and then reductions in savings from payments to hospitals serving the poor. So essentially reimbursement reductions to hospitals and other providers under the Medicaid program. And then there are a series of new taxes and fees that generate new revenue to help fund expanded coverage. And you can see those here. Excise taxes, the 10% levy on indoor tanning services. I actually saw that as what I hope is a cost shift from other states to the state of Arizona, because hopefully we're not accessing a lot of indoor tanning services. 3.8% tax on unearned income, interest and dividends, and other revenue sources. So what about the state of Arizona? There are some key decisions that have faced the state of Arizona. One, do we have a state-run health insurance exchange, or do we allow the federal government to run the insurance exchange for the state of Arizona? And as you probably know, Governor Brewer elected to have the federal government run the exchange for the state of Arizona. And then the second decision point, whether to expand Medicaid coverage. And as you probably are aware, the governor announced last week her intent to implement full expansion allowed under the law for the Medicaid program or the access program here in the state. Arizona voters have voted a couple of times for expanded Medicaid coverage, and we can get more into that with Dawn. And this full expansion of the Medicaid program is the only way that we can get full federal financial support. In other words, as we fund our Medicaid program in the state, the way the program works is we can draw down money from the federal government to match and exceed the money that we put into it as a state. So by fully funding our Medicaid program and Medicaid expansion, we draw down as much federal money as we can under the Affordable Care Act. Makes good economic sense for the state. Healthcare providers. There are fundamental changes afoot, I would say, as a healthcare provider, prompted by the healthcare reform law. The first is what we call shifting from sick care to well care. And this is primarily driven by changes in how we're going to be paid for the services that we provide. Historically, we essentially operated under what we call a sick care model. We took care of you when you were sick and you needed to come to a doctor or a hospital or another provider to help get you well. And we were paid for everything we did to help make you well. We weren't paid to coordinate care across providers, across hospitals and doctors. We were paid essentially for an episode of care. You come to us, you get a test, we get paid for it. We're shifting more to what we would call a well care model, where the payment is more focused on helping you actually get the care you need in the most appropriate setting. Stay out of the hospital, honestly, because the hospital tends to be the most expensive place you can get care. Penalties for readmissions are an example. In the past, if you got sick, you came to the hospital, we took care of you, we sent you home, and you came back within a short period of time, we got paid again. That's not going to happen anymore. So now you get sick, we take care of you, you go home. If we haven't done an adequate job and you end up readmitted to the hospital, we don't get paid anymore. We're on the hook for the cost of that care. That's what I mean. Our world is switching to a world in which we're focused on actually keeping you well, keeping you home, keeping you out of the hospital, which is a total mind shift for hospitals and doctors. More primary care and less acute care. So as we get paid differently, we have a real incentive to promote the fact that you will go to your primary care physician, get preventive care, get your annual checkup, get the services that you need at the doctor's office, keep you well, keep you out of the hospital. This concept of value-based purchasing, this is a phrase that we use in the provider industry these days. What it means is when the Medicare system, when government-funded insurance organizations buy care from us, they're starting to pay us now and incentivize us based on things like quality of care, efficiency of care, not just for doing a test or providing a treatment, but they're actually giving us financial bonuses based on how well we provide that care and put it and make sure that it takes place in the right setting. Value-based purchasing. Purchasing healthcare based on value rather than for just doing a test or doing a procedure. We also have financial incentives to collaborate among doctors and hospitals, things like bundled payments, accountable care organizations. These are new ways of incentivizing doctors and hospitals to work together to make sure that if you need care in a doctor's office or if you need access to primary care, we all are working together and we get financial payment from Medicare and Medicaid to coordinate your care rather than on an episodic basis based on just your bouncing around the healthcare system. Incentives to innovate. There are a lot of dollars within the Affordable Care Act, grants to try new models of care, to keep you well, to keep you out of the hospital. One great example is the medical home model. We have a group of primary care physicians within Dignity Health called the St. Joe's Primary Care Group. In early 2011, this group participated in a grant called the Medical Home Program. Basically what that means is there are financial incentives afforded to these physicians to keep their patients well, to manage their use of high-cost services like the emergency room in hospitals, keep them out of the hospitals. And we saw dramatic results in that medical home model, on the order of 20% reductions in emergency room visits, significant reductions in hospitalization. So folks stayed well, they stayed out of the hospital, they got care in the most appropriate setting. That's the kind of incentive that's built into the Affordable Care Act.